Hello, I'm Dr. Arifa Cassaboy, a practicing internist and a medical editor for Medscape and WebMD. In this week's brief on recent medical news and findings, we first look at penicillin allergies. While about 10% of the U.S. population reports a penicillin allergy, a recent study in the inpatient setting found that only about 1 in 10 of those labeled penicillin allergic were actually allergic. And this incorrect label in the EMR is dangerous. It's associated with higher rates of hospitalizations and C. diff, MRSA, and VRE. In the same study, 34% of the patients on antibiotics were switched by their medical team to a more narrow spectrum penicillin or cephalosporin once their penicillin allergy label was removed. And a recent survey of clinicians found widespread misunderstanding about penicillin allergies. A sizable number of respondents, 42%, didn't know a penicillin allergy can resolve over time. And over 80% of clinicians never or rarely consulted an allergist or immunologist to confirm a reported penicillin allergy. So, if the EMR says that your patient is allergic to penicillin, consider a deeper dive to determine whether the allergy is real. It might avoid unnecessary broad-spectrum antibiotic use in their future. Next, clinicians are being urged to reevaluate their use of levothyroxine in patients with presumed hypothyroidism. There's evidence that the drug is being overprescribed. In fact, it's the most prescribed drug in the United States, and prescriptions have risen significantly in recent years. Yet, an editorial from Mayo Clinic authors explains that there's been no real increase in the incidence of hypothyroidism. They blame the rise on earlier recommendations to treat subclinical increases in TSH levels, even in the absence of symptoms. They suggest that prescribing levothyroxine to treat subclinical hypothyroidism should be considered on a patient-by-patient basis, and then only after at least 2 elevated TSH levels measured 3 to 6 months apart. Patients with nonspecific symptoms and normal thyroid function tests do not benefit from therapy. And last, the U.S. Preventive Services Task Force has finalized its guidelines for prescribing statins to help prevent cardiovascular disease. The key points are: low to moderate dose statins should be considered for adults aged 40 to 75 years who don't have a history of cardiovascular disease, but who have 1 or more risk factors, such as dyslipidemia, diabetes, hypertension, or smoking. Also consider statins for those who have a 10% or higher risk of a heart attack or stroke based on their 10-year cardiovascular risk equations by the ACC and AHA. Even some of your patients with a 7.5 to 10% risk for an event in the next 10 years may benefit. The task force also concludes that there's not enough evidence to recommend starting statins in adults 76 years and older. It should also be noted that these guidelines are not for patients who are extremely high risk, such as those with familial hypercholesterolemia or those with LDL levels over 190. You'll find links to each of the stories we've included in today's news brief in the transcript listed below. For Medscape and WebMD, I'm Dr. Arifa Cassaboy.